with thyroid cancer. Are we overestimating? Absorption when the suspected how to approach by
السلام عليكم. تاني برحب بوجود حضراتكم. So we saw the case just presented with our review resident. To sum up this case, she's a 39-year-old female with both thyroidectomy and hypothyroidism. She came with classical clinical manifestations of hypothyroidism, and she's approaching to take 1 milligram of thyroxine, which is quite a very, very high dose. The patient admitted that she's adherent to the medication. On performing a workup for thyroxine malabsorption, the patient had an infection for Helicobacter pylori, and the upper GI endoscopy revealed the presence of anthrogastritis together with anthrovenous ulcer. Thyroxine absorption test came back to show that the patient is not absorbing her thyroxine well on this case. Let me tell you, this is a classical case for description of what is known as refractory hypothyroidism. So refractory hypothyroidism, as said by the expert consensus, is biochemical or clinical evidence of hypothyroidism with the TSH exceeding the upper limit of the normal 4.5 millinternational unit per liter, or the presence of unresolved hypothyroid symptoms despite the patient on levothyroxine sodium more than 1.9 mg per gram daily. So I guess our patient fits well to this definition, as long as the patient is not controlled, the TSH is 38, and the patient is receiving almost 10 microgram per kilogram daily of thyroxine. So what is the next step? Most physicians resort to gradual increments in the dose of thyroxine to supraphysiological levels so that it may impose an increased risk in terms of warning. So please refrain from this protocol because you are superimposing side effects for your patient. So let us discuss some important facts. As you all know, that primary hypothyroidism is quite common, affecting almost 5% of the normal population. And as said by the American Thyroid Association, levothyroxine sodium is the mainstay of treatment. Absorption of thyroxine occurs at almost 2 to 3 hours following ingestion of thyroxine. So when we are going to take it in a tablet form, the available route here at Egypt is going to go for disintegration followed by dissolution. And please mind you that for absorption or for disintegration of the oral form of thyroxine, it needs a physiological pH, that's to say an acidic pH. So the tablet form of thyroxine, anything that alters the pH is going to affect the absorption of thyroxine. Afterwards, let me tell you a very important recommendation that thyroxine must be taken on empty stomach to refrain from any food intake or beverages for an hour following ingestion of thyroxine. An alternative method to receive thyroxine is to take it at bedtime and ingestion of thyroxine. You should instruct your patient to avoid any dietary supplements or medications known to affect the absorption of thyroxine. After being diluted and dissolved in the stomach, it's going to undergo intestinal absorption in the upper jejunum and in the liver. Absorption rate occurs at the rate of almost 60 to 80%. After being absorbed from the intestine, it's going to go bound with plasma protein transported in circulation, and then by deiodinase enzyme is going to be converted to T3, the active form of thyroid hormone, and hence perpetuating the metabolic function of the thyroid hormones. Most of the patients will need a weight-based equation in order to receive thyroxine and to render them euthyroid by calculating 1.6 to 1.8 Eg per kilogram per day. So does refractory hypothyroidism essentially mean that the patient is not absorbing her thyroxine well? And classically, the answer is no. Anything that will affect this cascade will end up with affection of the thyroxine requirements, and the patient won't be controlled well and will be facing a case of refractory hypothyroidism. So mind you, it's not all about malabsorption. The gastroenterologists are not only ones implicated here in the story. A lot of factors may cause refractory hypothyroidism. This is why an expert consensus report was performed in the year 2017 trying to solve this problem, and they set a differential diagnosis for refractory hypothyroidism starting by decreased bioavailability. So decreased bioavailability means that the patient is receiving different forms of thyroxine with different pharmacokinetics, different bioavailability, different absorption, and this is why if the patient is going to change between them, the patient won't be adequately controlled. So as you can see here, this is examples of the branded form of thyroxine and the generic form. They are made of different substances known as excipients, the substance that they are going to carry the active ingredient in the circulation. So they are different from one preparation to another. So please, it is recommended again. And I was glad to supervise this prestigious research. A multi-source levothyroxine sodium tablet market in Egypt interchangeable, and we came with a recommendation: don't exchange between brands and generics or between different generics. Poor adherence or intolerability to thyroxine may be a cause of refractory hypothyroidism, and mind you, this is the most common cause of refractory hypothyroidism. It's not all about absorption, it is about patient compliance and adherence. And this was given the name pseudo-malabsorption. So pseudo-malabsorption was raised if I'm facing a case with inadequately controlled hypothyroidism. Am I facing a malabsorption or pseudo-malabsorption? And here comes the answer: most probably are facing a pseudo-malabsorption. Please check your patient adherence. So pseudo-malabsorption was first described by Ain and his colleagues back to the year 1991, when he found 4 patients inadequately controlled on thyroxine, and when performing thyroxine absorption tests, all of them came back to be absorbing thyroxine well. However, these patients aren't complying on treatment. They are not following the instructions given to control the case as well. So it is a factitious disorder giving the appearance of malabsorption, however, it's not a malabsorption. Pseudo-malabsorption remains a challenge for endocrinologists, and how we are going to solve this challenge by offering the patient what is known as levothyroxine absorption test or LC4 absorption test. The concept that, as I told you, from 60 to 100% of the ingested thyroxine is going to be absorbed. So what we are going to do, we are going to give the patient a big dose, including dose of oral thyroxine in hospital under medical supervision. The patient is fasting, omitting his morning thyroxine dose, and no medication whatsoever is instructed to be taken that may affect malabsorption or absorption of thyroxine. This is set to be the gold standard to differentiate cases between true malabsorption and pseudo-malabsorption. Marked rise in 3T4 following the loading dose of thyroxine exclude that you are facing a case of malabsorption. And this is an equation for its calculation. There are different protocols adopted for thyroxine. I won't go into the depths. However, different doses, different investigations to be done in order to assess the response to the loading dose. Different duration of the test, starting from 2 hours up to 5 weeks. So different protocols are set, and up till now, we don't have a definite consensus for the best way to do it. However, the best protocol or the most adopted protocol is to give your patient around 1,000 mg of thyroxine, and then to test 3T4 or 2T4 on an hourly basis for 6 hours, and then calculate the absorption rate. The third cause will be dietary supplements, diet and food and medication that may affect the absorption. And as you can see here, we're having a long list of dietary supplements, calcium, iron, preparations, medications that may affect absorption. Dietary habits, you may find that grapefruit, coffee, the papaya, a lot of food elements may affect the absorption of thyroxine. This is why it is recommended to space between these food items and thyroxine ingestion. A meta-analysis and systemic review was performed and conducted in this context, including 63 studies in order to search for food elements, dietary supplements, and medication that may affect the absorption. And they came with a recommendation spaced between these implicated or accused items and thyroxine ingestion by 2 to 4 hours, ideally 4 hours. The medication that may affect, either they affect the transport of thyroxine, so it will increase the thyroxine requirements, or it may alter the LC4 metabolism by acting on the hepatic cytochrome B450, or may affect the deiodinase enzyme converting T4 to the active form of T3, or directly affecting the absorption. And among the list of medications that may affect the absorption of thyroxine is proton pump inhibitors. A lot of patients, they do take proton pump inhibitors and they are instructed by the gastroenterologist that they take it at the morning before breakfast, and it may cause malabsorption of thyroxine. So bear in mind BPIs, calcium supplementation, iron supplementation, chromium, orlistat, quinolones, namely ciprofloxacin, a long list of drugs may affect the absorption, so it is recommended to space between different these medications and thyroxine dose. True malabsorption definitely may affect the thyroxine requirements in the patient and may render the patient hypothyroid. It may either affect the gastric absorption or the intestinal absorption, namely Helicobacter pylori infection, arthritis, bad gastritis, gastric atrophy, motility impairment on the intestinal level, causing malabsorption as lactose intolerance, celiac disease, small intestine bacterial overgrowth, parasitic infestation as gardiazes, and motility impairment. Bear in mind that gastric bypass surgery, either restrictive or malabsorptive surgery or blend between them, may again affect the absorption of thyroxine, and it does impose a challenge for us post-bariatric surgery to render our patients euthyroid, because definitely the thyroxine requirements will be different. Increased needs of thyroxine will be another cause for refractory hypothyroidism, either due to pregnancy, and it is said by the American Thyroid Association that upon conception, if you are having a patient hypothyroidism, automatically you will need to increase thyroxine ingestion 20 to 30 of the basal level in order to control your patient with the control level or limits set by the guidelines. Weight gain is another cause of increased requirements to levothyroxine. Let me give you the diagnostic algorithm. How am I going to approach to a case coming with refractory hypothyroidism? Taking the megadoses of thyroxine. Don't increase your thyroxine dose before adopting this algorithm. Starting by time, you need to exclude pseudo-malabsorption. Mind you, the most common cause of refractory hypothyroidism. Medication should be excluded. Dietary supplements, food items known to affect absorption. After absorption, all of these, you will need to perform a thyroxine absorption test, as I told you. Then, with the collaboration together with the gastroenterologist, we are going to go for malabsorption protocol, starting by the red blood test in order to exclude Helicobacter pylori infection. If it is positive, it's going to be eradicated as our patient. If not, go for assessment of gastremia and carcinogen, and then you are going to go for upper gastrointestinal endoscopy. And I'd like to thank Professor Emmanuel Banda. She's us here. She's the gastroenterologist who performed our patient. Thank you for her and for all our eminent gastroenterologists present here, Professor Aizahari and Professor Abdul Rahman. Upon upper gastrointestinal endoscopy, you may need a biopsy to exclude celiac disease, gastric atrophy, and antral gastritis. If the patient, another way in our algorithm to go for a lactose breath test in order to test for lactose intolerance, and accordingly, you are going, if excluded, you are going to continue your algorithm by performing stool examination in order to exclude parasitic infestation as gardiazes. And if the patient is having a sort of bacterial overgrowth, you are going to prescribe your patient the proper antibiotic treatment. So this is the algorithm that you are going to follow if you are going to see a case with malabsorption. Let me give you the take-home message. Refractory hypothyroidism is failure to reach euthyroidism in hypothyroid patients, despite the patient is taking megadoses of thyroxine exceeding 1.9 mg per deciliter. The most common cause is pseudo malabsorption. The best way to differentiate between pseudo malabsorption and malabsorption is by performing levothyroxine absorption test, despite up till now no definite consensus for the adequate way to go forward. And by this charming picture for our lovely City Alexandra, I end my presentation. I do thank you.
السلام عليكم ورحمة الله وبركاته. صباح الخير. سعيد جدا بوجودي معاكم. أشرف إلقاء محاضرة اليوم بإضافة للسبيشاليتي. أشكر اللجنة المنظمة وصراحة أعضاء أنها ذكرت الضيافة تجربون شرفكم واستضافتكم وشكرا جزيلا. So when we talk about patient thyroid, we have to define what type of patient we are aiming. So in most of the case, in that we almost recently we all agree on is ablation of benign nodule that is causing symptoms. And this benign nodule should be non-functional nodule. So when you decide about ablation of thyroid nodule, you have the benign, non-functional. Then we talk about solid, cystic, or mixed nodule, and we have no doubt that we are all agreed that there should be no problem with this if it is causing symptoms. There will be some talk about functional benign nodule or malignant benign nodule. If it's malignant nodule for therapeutic or palliative reason. So there is limited evidence, limited indication to use the ablation for malignant nodule or for functional nodule. So most of my talk today is about benign and functional nodule. So basic of thyroid nodule, this slide is only one slide, and it is talking about basics. So you have a thyroid nodule, you consider FNA if it's more than 1 centimeter with highly suspicious chorographic feature. If it's more than 1 centimeter, you are intermediate suspicious, so this is strong evidence, again strong evidence. And it's more than 1.5 centimeter with low suspicious photographic, it's also weak accommodation, or more than 24 foot with low suspicious photographic better. Sometimes you may agree that this number 3 and number 4 may not need to have final aspiration. But when we are talking about thermal ablation or alcohol ablation, we must rule out the malignancy even in a low-risk nodule. So I attempt to bring this slide from American Thyroid Association that all of this nodule need to be biopsied. If you are thinking or if you are preparing the patient for thermal ablation. Alright, so there's 3 things need to be fulfilled. 3 criteria need to be present in a patient going for thermal ablation or thyroid nodule ablation. Number one is the thyroid nodule. It must be benign, or at least most likely benign. This nodule causing symptoms, so it can cause pressure symptoms, or if there is a cosmetic concern for the patient, and the patient declines surgery. All right. So, for benign cytological diagnosis, benign cytological diagnosis is needed, and a repeated fine needle aspiration must be done. So, in most of the recommendations, most of the guidelines, they are requiring 2 fine needle aspiration to be benign or completely benign, except in a very low risk nodule like sponge form or juices. So 1 is enough. Just to remind you that the risk of malignancy, even with a benign cytology, is still there, and it's ranged between about 1.5 up to 3%. That what we call false negative. So there's a false negative. When you trust your endocrinologist, interventional radiologist, that he's doing the right thing, targeting the right review. In this case, the targeting will be perfect and the results will be nice. In patients who has no symptoms, so if he had a thyroid nodule that had no symptoms, there is no indication to do ablation, providing the nodule is benign. And it's actually a difference. And I think in your practice, you know that some of the patients had even larger thyroid nodule and had no symptoms. But we think that 3 centimeters maybe is the cutoff of having some symptoms. It also depends on where is the thyroid nodule. So maybe in the isthmus, when there is a small amount of tissue, normal tissue, may make a difference. So the patient who has isthmus area nodule may have more symptoms than people who's having the thyroid nodule in the loop, or one of the loop. It is between genders, so female may concern more about the cosmetic concern, or they have more concern about the cosmetic issue than male. Also, thin and obese patients have different appearance of the thyroid nodule. The third thing is that the patient is declining other plan. But the plan of surgery should be discussed with the patient. So the surgical option must be discussed with the patient before you decide to send him for further ablation. Just to tell you about the natural history of a benign nodule, that 15% of the nodule may grow more than 20%. And this is something you can discuss with the patient that need a future plan. So you can tell him that, maybe 50% of the time the nodule is going to be larger by 20%. And at the other hand, some of them will decrease in size. So this is also something you need to keep in mind and discuss it with the patient. And as we mentioned, the malignancy is still there. And as we always discover with the fine needle aspiration data, with the surgical data, that actually the size doesn't matter. So with this patient who developed malignancy, the size did not change. All right, so most of my work was in the cystic nodule, and the definition of cystic nodule in some of the guidelines of authority, they think that cystic nodule is any nodule with cystic component more than 50%. And is it common? Yes, it is common. It's up to 37% of all surgically excised thyroid glands are cystic. And aspiration maybe is the treatment of choice, so we do the aspiration for the first time, we don't ablate it the first time, because most, the current rate is range and varies from 10 to 18, but 80%. So some of the patients will have the aspiration as enough procedure, and it may which is recommended as a first line treatment among all the thermal. So there is the ATOH, radio frequency ablation, microwave ablation, laser ablation, and in cystic nodule, ethanol is the first choice for our patients, and reduce the volume between 50 to 98%. What is the negative factor that influence if there is the solid area is more than cystic area, if there is multi-regularity, if the volume is more than 10 ml, and if there is increase in vascularization among the thyroid nodule. We insert the needle when we inject the alcohol, the show. And this appearance can also help you to target the therapy. So, as I mentioned, the ethanol ablation is first choice, and you can see there is no difference between radio frequency ablation and ethanol ablation in cystic nodule or baby cystic nodule. For the solid nodule, the procedure is different. The ethanol is not very effective, and the most important procedure we are using for solid nodule is the laser radio frequency ablation and microwave ablation, and it all gives a good result in reduction of the volume of the nodule. And you can see here that radio frequency ablation, microwave ablation can be also used for the cystic nodule. However, the ethanol is enough, easier, cheaper, and at this frequency. And the complication of the procedure is very low for most of the technique. So, laser radio frequency ablation. So I'm not going to talk in detail about the procedure, but you can see here the gauge of the needle is this with microwave, larger than laser. The watt power is different, and the laser needs two operators. So there's two persons working in one of you. There are other three, so one operator. And there needs some experience with the microwave and radio frequency ablation. It's having the moving target technique to target the area of the nodule that you need to biopsy. This is actually local data from Saudi Arabia so it's different data. Radio frequency ablation, microwave ablation. And to be honest, that microwave ablation is not fair for this procedure because it's not very commonly used in North America, and it's maybe used in Asia and some area of Europe. Radio frequency ablation has used more in North America and even in some. So this is the radio frequency ablation, and it's almost the same procedure of the microwave. It's a probe inserted from the above the isthmus, and it's directed to the thyroid nodule. we have to remember that it's a dangerous target, or dangerous triangles, where you have the capillary region there, the surface. Also, this is vital organ need to be avoided. You start distally, then you go up, which we call the moving target. So again, so when you ablate, there will be some appearance of bubbles. So and it depends on the technique that you are using. Sometimes you have to wait until there's a signal. Sometimes when you are using the microwave, there's a specific time you have to keep the thermal effect for some time. You move medially and you ablate for the other part of the thyroid nodule. And this is a study that combined the alcohol with frequency ablation. So the solid nodule. So you have the solid nodule, you inject alcohol in different places with the small amount of alcohol. Then you do the ablation with radio frequency ablation, and it showed actually better result than the radio frequency ablation alone. This data from Egypt, actually there's a good data from Egypt, and it showed very significant reduction in the volume of the nodules. A quick three slide about the autonomous function thyroid nodule that we are not, as endocrinologists, referring much to this procedure, and but the thermal ablation for the toxic nodule showed good reduction, almost 80%. The effect on thyroid hormones, normalization of thyroid hormone, depend mainly on the nodule size. So if you have a larger nodule, but it's not considered as a first line therapy for autonomous functional nodule, and it may be considered for a young patient with a small functional nodule, and if there is also high surgical procedure, if the patient refused the surgery or radioactive iodine, and this is the only way to control his thyroid function. For microcarcinoma, there is a good work from England and from Europe, and they showed that there's no suspicion of lymph node metastasis, disappearance of the papillary thyroid carcinoma, no major complications from the surgery. However, we know from our practice, from the paper evidence, that active surveillance maybe is enough. So anything we will do to be showing good results, and leaving the patient alone with active surveillance maybe is good enough in this case. For recurrent thyroid cancer, and this we do more frequently than for microcarcinoma, which is ablation of recurrent of the thyroid cancer in the thyroid gland or in the lymph nodes. If the patient is not ready for surgery, or the surgery is contraindication, or the patient refuse the surgery, we do lots of alcohol injection, and also you can use the radio frequency ablation, microwave ablation for the recurrence of the thyroid cancer and thyroid node, or actually in the lymph node if the patient had symptoms. Again, it's not indicated as a first-line therapy surgery. Aiming for cure is the best way to go. However, some people have refused the surgery, or the surgery is doesn't. So this is radio frequency ablation, picture from radio frequency ablation, and this is for the microwave ablation. You can see there's things. I don't have much experience with high intensity focused ultrasound. However, there's no needle can be inserted, and I think that was my last slide. Thank you very much.
frequency ablation of thyroid nodule. Any question, please?
But I want to ask, have you done work of ethanol injections in use? Yes?
Thyroid.
Ethanol
Ethanol, yeah.
right? Did you follow up these cases
Yes.
for years?
Yeah, I have patients for 10 years and 15 years doing this.
There is no predisposition for changes in the malignant function.
Yeah, most of them they have really small. I remember one patient, he had the surgery after 10 years, I think, or 12 years. Young guy who we injected the alcohol, and for some reason he had a surgery and it was benign. I'm sure there's some of the crime surgeon there. They actually don't like to operate in somebody who had alcohol injection or baby pregnancy ablation because of the issues with the fibrosis. However, I think that's my first slide, that you have to choose your patient very well. You have to rule out the malignancy, and by at least the solid reduced to 2FNA, and make sure this patient is not going to come back after 10 years or 15 years. You say, oh, doctor, you inject malignant nodule, and that's my point. And this is a message for our colleague that they are who's doing the lots of radio frequency ablation, and in fact we have lots of cases. They are not ruling out the malignancy. They are not doing the right thing. They are not doing the fine needle aspiration. They may do. I remember a case. They do FNA now. And I think after half an hour, they do another FNA, and they have their pathologist there who says, okay, this is okay, the second one is okay. In one day, and you do that patient in one session. It's, I can't believe it sometimes. We have a story that somebody is doing ultrasound, and during doing the ultrasound, he offered to do radio frequency ablation at the same time without finding aspiration. So the message is you need to make sure that thyroid review and basic is basic. APC, the patient needs to have final aspiration without malignancy, wait for 3 months, wait for 6 months. If there is no malignancy in the final aspiration, rule it out. Then you can consider other option. Surgical option must be discussed with the patient before the thermal ablation of alcohol.
Thank you.
Good morning, Dr. Anwar. Thank you for your nice presentation. I have two questions. The first of them is, what is the cost of radio approximately?
Well, it depends on where you do it. So in private section, it can reach to 10 to 15,000 riyals. So it's very expensive. More expensive than sometimes the surgery, or it's equal to the surgery. It's less than the surgery.
Yeah, and the problem is single use. I think.
Single use, disposable.
Yeah.
There is one slide of the cost. I just passed it, but for the alcohol injection, it doesn't cost anything.
Yeah. But for the assumption, I have many cases have been already updated on injection of alcohol. Then she's indicated again for surgery due to recross and due. For me, the problem that the surgical plate is not so good like virtual plate. You find like adhesion, like bruises.
Yes.
I just had 1 week ago a case with trial thermal ablation. And after that, it was very adherent to the recurrent, very adherent to the trachea. Actually, expected to be a benign case with the surgical plate, clear surgical plate, but I think after ablation, usually there is a changes in the surgical plate.
Ablation of the thyroid?
Radio frequency.
Radio frequency.
Yeah. And after that, we do the surgery like 6 months after the radio frequency. And it was like I had.
It's a lot of fibrosis. I agree. But
I measure to decrease this. I mean, there is any measures for you if you to try ablation to decrease this adhesion around the tubes. I mean, to avoid extracapsular vascular thermal or what. I don't know.
Yeah, I think it's about who did it and what's the way of doing this. Because if you think it's a nodule with a capsule, and you enter with the rope and you ablate inside the nodule. So why we have to have that's why I'm asking ablation? Fibrosis to the trachea. I think it's a technique thing. It's experience thing. And but I agree with you that actually my partner, my Professor Abdulaziz is a surgeon, blind surgeon. He warned me. He said, "Don't send me something you inject with us." So
Professor Anwar, thank you very much for your good lecture. I'm a surgeon. My name is Thyroid here from Alexandria. As a matter of fact, I would have asked the same question my colleague asked about the feedback from your surgeons operating after. But I think we got it. My question is, what is the percentage of the volume reduction of the thyroid node that is satisfactory for you?
It's for not for me. I mean for universal number that they call it successful is that more than 50% reduction in the size of the nodule. And for me, I think most of the cysts that I do, it's way more than 80% because we aspirate everything and we inject the lips. So the cyst is like this. So when we aspirate, so it will become like lips. Then we inject the alcohol there, and it's rarely come back. But it's 50% that what they consider.
And about the solid nodules, do they grow back again? And if this is right, for how many years do you have to follow them?
For solid nodule, I rarely do the alcohol, and it's the successful rate of radio frequency ablation and microwave ablation is very good. So it's exceeding 80%. But I almost in 99% of the case, I try to push the patient to go to choose the surgery in solid nodule, especially if there is suspicious feature.
Thank you.